average attendance at monthly meeting has been totaling 15 and 20. We look forward to having each and every one of us to enjoy
Dr. Regina, please, you can take over from here. I think she has a network issue.
Okay, I guess we'll leave the report where it is because our time is already far gone. Pharmacist Jude, please, can you take the presentation? We have said our topic is therapeutic drug monitoring, a lighthouse beacon. Please, Dr. Jude Pam, a chief pharmacist with the University of Jos Teaching Hospital. He has been there for 11 years, and this presentation is actually not new. He has taken it before, so I believe he's very good at what he's about to tell us. Let us give him attention. Pharmacist Jude, go ahead with your presentation.
Thank you. So we're talking on therapeutic drug monitoring, a lighthouse beacon. So the lighthouse, I use it as a comparison to therapeutic drug monitoring, in the sense that
you are here to share your slide. Kindly share your slides. You are here to slide.
My slide is okay. Sorry,
it's not on yet. It's not on yet.
Okay, sorry. Can you see? Okay. So,
oh no. Oh no.
Okay, thank you. Okay. So as I was saying, the lighthouse, I use it as a comparison to therapeutic drug monitoring because of some similarities that they share. The lighthouse is mostly seen in developed countries, and for a good reason. It tends to provide a guide by emitting light to most maritime pilots in sea, and this is for the purpose of guiding them through dangerous coastlines, hazardous reefs, and rocks to prevent any damage as they go into the harbor. So, with that in mind, the TDM is also similar to that in the way it works, as well as its concept. But in this case, we're talking of drug therapy and management in patients. So the question now is, what does it entail for health professionals in our ever-demanding practice, particularly pharmacy, and how does it benefit us or make our service better? Literally, the aim of drug therapy is simply to provide an effective medication against a disease or ailment while trying to avoid a toxic situation. And usually that is a very thin line that whenever we're managing patients with drugs. And I remember in our school days, our lecturers always emphasize that drugs are poisons and they should be treated with respect whenever they are being used. And in the course of drug management, you may come across multiple drug medications, and this provides or presents some challenges in management. Therapeutic drug monitoring will simplify this management and make it a bit easier for patient therapy, patient drug therapy. Also, there are tools that are used alongside TDM. They're used to ensure TDM is practiced properly. And you have the pharmacodynamics and the pharmacogenetics as well, and also reliable methods in gas chromatography, spectrophotometry, and HPLC. Although they have added challenge, which I'll mention later in the presentation, but they are also precise forms of using. By definition, therapeutic drug monitoring is the use of drug concentrations in body fluids as a means of managing, or rather ensuring patients receive a, a particular concentration that will be suitable, or that will end up with a cure or alleviation or prevention of that particular disease. It's a means of measuring drug concentration at specific intervals to maintain a constant drug concentration with the sole aim of optimizing patient drug regimens. The end goal, obviously, is the cure rates of that particular element. The tool helps guides clinicians and pharmacists to provide effective and safe drug therapy to the patient. And the end goal of any management is the cure rate or the complete aspect of that illness. And it's worth mentioning that there is a significant relationship that exists between the plasma concentration of the drug and its clinical effect forms. And this forms the basics or the foundation and concept of therapeutic drug monitoring. So the question is, why we employ therapeutic drug monitoring with the fact that other means of management are in existence? In today's world, drug assays are expensive, either due to their equipment or the personnel that are employed. And TDM was born with consideration in the sense that monitoring and obtaining additional information will be much more beneficial than these assays. Some classical examples of TDM include acetaminophen toxicity, and also some drugs like vancomycin and salicylate, which mindsets are over-the-counter drugs, and you can, particularly salicylate and acetaminophen, and they are OTC drugs that can easily lead to poisoning without quick management if the situation is determined. So TDM should be strictly applied for clinical meaningful tests, and I see this with all emphasis, in the sense that in the next couple of slides I will show you why it should be used specifically. So there are some key parameters that should be kept in mind whenever we're using the therapeutic drug monitoring, and they include toxicity, dosing, and monitoring. So in the instance of toxicity, whenever adverse drug reactions are noted, it is most likely that the drug is the concentration is not suitable for clinical cure rate. And one of the cornerstones of TDM is to avoid toxicity. Also, dosing. In an instance, whenever a loading dose is given, it's important to monitor that concentration of that drug just after the first dosing. And this is monitoring. This is monitored after said intervals, be it 3, 4, 5 hours, depending on whoever is managing that patient. And this can also predict what the next dosing, the dosing amount would be. Obviously, monitoring is a key aspect of TDM as well, in the sense that patient compliance is also observed, because compliance is essential to the success of TDM. If the patient adhering to the instructions by the physician or pharmacist. Also, is there a situation where the drug is there a situation of underdosing or overdosing? And the beauty of therapeutic drug monitoring is that the plasma concentration can determine whether a situation of underdose or overdose has occurred. If the therapy does the management of the illness in question now is it achieving? Are we achieving any cure rate with managing a patient with different drugs? That will be the end goal. If not, then obviously the therapy has failed, and TDM will most likely detect that. So there are some notable scenarios where therapeutic drug monitoring is used, and we see them literally every day whenever we go out or we attend to outpatients during situations such as drugs that may have low therapeutic index. This is a very important point. And whenever we come across drugs with low therapeutic index, we should always keep at the back of our mind that the patient can easily have a toxic situation, and the dosing should be noted. As I mentioned earlier on therapeutic failure, that is more or less under treatment, under dosing. Let's say particularly antibiotics. When you give a low dose, you're pushing the patient, you're exposing the patient to low amounts of the drug, which can lead to resistance, and also the patient, the drug won't be so much of better use. Another situation where TDM is employed is major organ failure, in the sense that particularly drugs of metabolism, i.e. the kidney or the liver. And these drugs, these organs are very critical in drug elimination. If the situation arises where such organs are failing, such drugs will be eliminated and they will build up in the system and cause further problems. The issue of non-compliance I mentioned earlier with patients, and there's non-compliance, any guarantee of drug success is severely hampered. Prevention of adverse drug problems is also there. When there's a poorly defined clinical endpoint, and this is more or less associated with poor the goals set at the beginning of therapy. If they're not achieved at the end of therapy, obviously, TDM can easily identify where such problems arise. Also, there are drugs that, that's the last one, guiding withdrawal of drug therapy. There are drugs that we place patients upon that if there's a set, if we're achieving our target, that drug is slowly and steadily withdrawn. An example is corticosteroids, and the withdrawal is done slowly because of their modulation. They modulate and modify some set systems in the body. However, with this at the back of our minds, we should also note that there are situations where TDM is not really required. And this point that I listed down will help differentiate such situations. Drugs that may have wide therapeutic index, where if you go above this the said adult dose, it might not be an instance of poisoning. Where pharmacological effects can be clinically quantified. In such kind of patients, you know what will be the endpoint, and you expect the first situation to occur. And a classical example is the patient having prescribe analgesics. You expect the headache to be controlled. And also situations where the dosage does not need to be individualized. In this situation, because of several parameters, which I'll also list later in the presentation, such drug dosages that are prescribed will attend and resolve whatever situation that they're being managed for. And also, lastly, where the plasma concentration of the drug is not clearly established. So in the next table, I have just a little example of several notable drugs with low therapeutic index that are properly prescribed. So and the second row, the four, that's the stage before, after the loading dose. That we talk about the maintenance dose now. You have steady state reference in each of the drugs that are listed. So literally, if you go beyond each of these therapeutic levels, you're expecting toxicity. So for morphine, for example, you have a therapeutic dose for adults as 10 and 20 nanograms per milliliter. If the TDM is used and the blood plasma concentration of such patient is over 1.5 micrograms per milliliter, you should expect ADRs or toxicity. And that goes on for all the other drugs that I've listed. And these are drugs that we use regularly. And as pharmacists, whenever we come across such drugs, we should always ensure that we apply this knowledge to ensure that the patient doesn't suffer silently such toxic situations, and they can be manifested as ADRs. Also, there are other general classes of drugs that are also suitable for TDM. They include antibiotics, antipsychotics, immunosuppressant drugs, anti-epileptics, bronchodilators, HIV drugs, antidepressants, cardiac drugs, and some cytotoxics. So, for basic pharmacokinetics, it's essential to have a basic pharmacokinetic knowledge for dosage adjustments. Therapeutic sources literally depends on achieving the set plasma concentration of a particular drug that will provide safety and be efficacious at the same time in managing a patient. Pharmacokinetic knowledge, as I pointed earlier on, can help interpret clinical drug concentration measurements of the patients. And this is done by constant monitoring of the plasma concentration of the said drug from the loading dose and maintenance doses. Several other factors such as pathology, physiology, and pharmacology can also have an effect on okay. Sorry, this is blocking. So as I said, several factors such as the pathology, physiological and pharmacological factors also alter drug disposition and that's in disease states. And TDM is essential in more or less cannot be altered. It's more or less focused on the blood plasma concentration. For drugs in which TDM is available, a therapeutic range, just like I listed in the table just before, is said to achieve the desired effect while avoiding toxicity. So what I have here is a hospital in the United States, and they generated a sheet for several aminoglycosides that they use in dosing. And they said, I mentioned pharmacokinetic parameters are used, and these include loading dose, like I said, maintenance dose at the time of indication, creatinine clearance, elimination constant, the half-life, and the eventual determination of the dosing interval. And these are all interlinked. So I have here a sample case of where TDM is being employed. We have Mr. AD, a 68-year-old male patient that had acute renal failure secondary to nephropathy. Other background comorbidities include ischemic heart disease and atrial fibrillation. He presented with a reduced urinary output 4 days ago with bilateral limb pains, generalized body weakness, and fever. The antibiotic regimen was modified to include oral clarithromycin at 250 milligrams every 12 hours to cover a infection that was determined on sensitivity, on request on sensitivity results. He responded well to that regimen. His other medications for the other comorbidities include famotidine, bisoprolol, isosorbide, dinitrate, and valsartan. He developed an unsteady gait after 10 days of clarithromycin. Then he reported that after 16 days of taking the clarithromycin of seeing worms all over his bodies and in the surrounding environment. The lab results, his creatinine clearance value was 8.5 ml per minute. He had no focal neurological deficit or cerebral signs. And a CT scan of his brain indicated cerebral atrophy, but there's no evidence of acute stroke. So I want to focus on the clarithromycin, particularly in this particular patient. So for the macrolides in kidney excretion, erythromycin and azithromycin are excreted via the bowel. So there's not much bile and feces that is required. Whereas in clarithromycin, the active metabolites are excreted unchanged in the urine. And in the instance of a renal challenge or renal function, there's a need for drug modification of the clarithromycin by as much as half if the creatinine clearance falls below 30 mils per minute. A further note of clarithromycin is that it's a cytochrome 3A4 inhibitor and also a P-glycoprotein enzyme inhibitor. So you would observe some added side effects in the patient due to this effect that it has. So here I have another table that indicates the normal adult dose and the dose that would be used in renal failure. So in clarithromycin, an adult dose in a normal healthy individual would be at 0.25 grams to 0.5 grams every 12 hours. If it's an extended release, you can go as high as 1 gram every 24 hours. But in a situation where there's renal failure and the creatinine clearance falls below 10 mils per minute, that drug, the frequency now should be extended to a day rather than 12, rather than a BD administration. And in the patients that we mentioned had a creatinine clearance of 8.5 mils, and this falls way below figure. So the drug modification will definitely be required for that patient, and that is all due to some further information that is required for TDM interpretation. Includes dose and frequency of administration, that's the dose of the drug at the first dose, and also the time intervals, the start of treatment, whether there's a change in dose, then also the time of sampling. This is mostly seen in the laboratory where blood is drawn and the plasma concentration of that drug is measured. Then also patient's physiological characteristics also have a significant influence, whereas B is the patient's age, B is the patient a child or an adult or in his older years. Weight also has an effect. Is the patient obese or lean? And sex also has a role. Past and present clinical past and present medical histories of the patients are also important in the sense that they can have an effect, just like I mentioned earlier on drug management. And if there's a situation where a patient is unresponsive to the treatment or there's a suspicion of toxicity, TDM is definitely required for such patients. The story of TDM didn't just start today. In most countries, particularly developed countries that have started TDM years before or decades before, they have recorded some successes. And these are just but a few that I came across. We actually, W. Olusoyan et al. This year actually employed therapeutic drug monitoring in adherent and non-adherent patients that were on carbamazepine monotherapy. In some South African nations, despite challenges of cost and personnel, in particular in Argentina, the unit of clinical pharmacokinetics at hospital, the pediatra GP Garan offers TDM to patients that both pediatric in and out patients, together with pharmacotherapeutic recommendations to other hospitals, surrounding hospitals within the country. TDM is also seen as an analytical tool in visualization of therapy to avoid risks of therapy failure of drug toxicities in pediatric patients. That was done by Simuri R. et al. 2022. What are the benefits of TDM? There are quite much. They help to reduce hospital congestion in the sense that treatment, the time rate for treatment is drastically reduced. There's also an increased quality and safety of treatment. And in terms of staff that carry out this service, there's a sense of productivity and esteem whenever we're dispensing such a service. There's also a considerable and significant reduction in pharmacotherapeutic management costs on a patient. And we see this in our hospitals today, where if a diagnosis if a patient is misdiagnosed, the drugs that are listed are also wrong, and that translates to cost and time that has been wasted. There's also an improved quality in life, this management of the patients. As I mentioned earlier on at the start of the presentation on the Lighthouse, I said they had similarities in terms of benefits and also drawbacks. The main drawback of therapeutic drug monitoring is the cost. The key is quite extensive and expensive in the sense that the equipment and the instruments that are employed. The key aspect of TDM service is that it requires, just like I said, equipment and a large number of personnel that need to be trained and retrained on a normal basis because of it constantly evolves. In developing countries rather, or poor countries that have poor access to resources, this can be a monumental challenge for them to implement TDM. And also, due to the lack of these scarce resources, there might not be a motivation in healthcare professionals to actually implement TDM. And earlier on, I said TDM may be affected by the physiological and pathological conditions that may have an effect on the final results. In summary, TDM is an essential and important therapeutic tool that ensures a timely and optimal and individualized plasma drug management. And these concentrations can easily explain efficacy or failure of a treatment and can also determine if there is a situation of toxicity. Utilizing key pharmacokinetic parameters, prolonged periods of ineffective therapy can also be avoided whenever we're using TDM. Several factors have influence on drug disposition, and TDM is used to ensure that it can easily adjust and manage these dosage regimens. Despite the drawback which I mentioned, which includes the cost and personnel, the overall look is that it's beneficial from documented data that we have seen. provides that advantage in therapeutic care management for patients. Thank you for listening.
Oh, thank you very much, our presenter. Thank you for doing justice to the topic, Pharmacist Jude Pam. We'll soon have the question and answer session. And I would like anyone that has a comment or contribution or question to raise the hand up for recognition. But before we go into that, I want to acknowledge the presence of, I have seen some professors with us. I want to let you know that we highly appreciate your presence at this meeting. And our national chairman has been with us from the beginning of the meeting. I want to recognize him and to give him opportunity to say something to us before we start taking the questions. Thank you very much, the presenter, for letting us know so much about the therapeutic drug monitoring, the purpose of it, and the kind of drugs that needs therapeutic drug monitoring. Thank you very much. Our national chairman, please, Dr. Joseph Madu, you have the floor, please. Okay.
It's not on the call again. Yeah.
Oh, it seems our national chairman is disconnected.
Excuse me.
Yeah.
Okay. I guess he will come back to us in the process of time. So can we take, Prof, please let us take your question. I can see your hands up.
Okay.
Please, am I audible?
Yes, you are.
They can go ahead and omit.
Hello. Can you hear me now?
Yes.
Yes,
Yes.
Yes, I have a small comment which is additional. While meeting the presenter, very smooth, very good delivery, and straight to the point. Even those who don't understand pharmacokinetics can easily follow those that are forgotten. Hey, there's just one practical input that I want to, most of us will possibly have forgotten, that when you are doing therapeutic drug monitoring, because of the cost, there are some indirect approaches as it relates to some diseases, particularly diabetes mellitus. Yes, you will note that we do therapeutic, fasting blood sugar, and we also do random blood sugar. A lot of people don't know that you have many forms of variants of random blood sugar monitoring. The first one that you do tends to know what the enzymes in the body are capable of doing. After the fasting blood sugar, after the 2 hour, now for critical people, for people who are critically ill from diabetes, you can have as much as 3 or even 4 point random sampling. And that is a way of now not monitoring the enzyme, but monitoring the drugs, the performance of the drugs, at least clinically. What I'm saying is the fasting blood sugar tells you the state of is diagnostic for diabetes. The 2-hour postprandial shows if the enzymes are all good. But after that, you have 3 points, 4 points for critically ill people. And that is a form of therapeutic drug monitoring, because now you are not now concerned about the enzyme. You are now concerned about the performance of the drugs. As you do 3 points or 4 points, random blood sugar, sampling. Are we getting my drift?
Yeah, I think I understand the concept. The concept idea.
The concept is that you can do an indirect TDM, especially when you don't have all the paraphernalia of testing the drugs, what amount of drugs are in the body. You can indirectly test the performance of the drugs, especially in diabetes, by monitoring the blood sugar.
Okay.
Now it won't be only one random, it will now be multi-random assessment. Thank you very much.
Thank you, sir.
Thank you very much, Prof. That is why we're always glad when you joined us, because we know you'll always contribute something impactful. Thank you very much, sir.
Thank you.
God bless. So now we want to recognize the National Vice Chairman, Dr. Maureen Wafo. Your hand is up. Please, ma, you have the floor.
Good evening, everybody.
Good evening.
I'm very glad that we are here tonight to listen to this great presentation. I want to thank everybody that made it possible to be with us this evening, despite the difficulties we had in some people that have taken our bet. We persisted, and here we are to listen to this wonderful presentation. I want to thank our presenter for this. Would I call it is what we need at this point in time in our clinical practice. So thank you very much for this comprehensive and concise presentation. I just have a question to ask. Have you seen the benefits and advantages of TDM? We all know that it's very, very important for us pharmacists to make sure that this process of TDM, so that we'll be sure that we are giving our patient the correct dose in order to prevent toxicity and all the rest. Now, we're in a post low resource income in our country, in a developing country, and most of our hospitals, let's start with the tertiary hospitals. I doubt whether we have those equipment that are for us to perform this TDM. So, practical is our dream that our hospital will have such equipment, because that's standard. But as of now, I know most of the hospitals don't have it. So in essence of that, I want to ask our speaker, we need to do something to help our patients. In absence of those equipment, is there anything we can do to make sure that our patients did go into toxicity, especially drug like aminoglycosides, drug that have low therapeutic index? What we can do in absence of those equipments to really make sure that our patients come down with toxicity and they get the correct dose? Thank you very much.
Okay, let me answer that question. Thank you, ma'am, for that very interesting question. In the course of my...
Thank you very much.
Okay. So, as I said, in the course of my research, there was something as I was going through, let me say, particularly in developed countries, as I was going through some of the structure that they have made for the successful implementation of TDM, there was something similar that I saw. They had, okay, I think I'll put it in two ways. They had like the revolving fund scheme that was able to sustain particularly equipment, let's say particularly equipment that are used in TDM. The other aspect of because it all comes down to funds. It's all about funds. So the first aspect is like revolving scheme. I think in our own country we can point towards revolving schemes, like let me say EBRF, where you have a revolving funds that are generated are also immediately pumped into buy input. So it revolves on its own. It's a self-sustaining system. So in developed countries, they have that system where funds or monies that are generated are sunk back into the system to sustain the TDM. Another aspect is government policy. Okay, government policy. So with this, in this profession that we're in, it's all about data and results. We can approach governments with certain data and results in the sense that whether it be a 10-year study, we present data that this study has indicated that the use of TDM as against a study that where TDM was not employed would save the government this amount of funds and that. So obviously the government will be interested in that. Anything that would save excess funds will also pay a listening ear. Another aspect that came to my mind is we could have donors or people that voluntarily want to key into TDM when they are being intimated on the benefits. So those are the things I saw during the course of my research. So if those it is obviously it will go a long way in putting the burden a bit, lessening the burden rather in our country that is developing. Thank you.
Pharmacist Palm, I think you can talk about the calculation, the basic calculations they can do, like especially for aminoglycosides and all that. Those ones that you could normally do in ICU. You can tell them about those basic calculations. Already, you gave the parameters that can be used for such calculations, but maybe you can send in the formula later so that we help them.
Okay. I should talk about the post.
You can talk about it. Talk about those calculations for those that don't have HPLC. How can they?
Okay, let me just go to the slides. Okay.
Well, I thank you very much for your contribution, Dr. Rachel, but I'm not sure how feasible it will be to do the calculation right now at this meeting. But we can all go back. The presentation is not exhaustive, kind of. We can still go back and learn more about the calculation in her therapeutic drug monitoring. This is just kind of giving us an insight on how to go about it. So I believe we can all go as individuals. That is why we are here to learn. When we learn, we go back and learn more about it. So thank you very much. And thank you, Dr. Jude. Please, are there other comments or
can I make
questions?
Can I make contribution to the question?
Okay, please.
Thank you.
Yes.
Thank you very much for what. My question, in absence of all those trying to get funds and all these things, still no front for now. That's my question. So for our colleagues that said that we should use the calculation, can use the calculation and get the correct based on your patient weight, based on the volume of this, of that particular drug, if you know it, you can still come down with the correct, accurate dose for that patient. So we can just, looking at your patient clinical status, for us that work, you can see of your patient serum creatinine, vancomycin, drug that needs renal dose modification. Those ones can help you to the actual dose. In case of low therapeutic index, like you make use of your patient's IML, you can still use that to at least get the adequate dose that will not lead the patient into toxicity. And for others, you may not really get by using the serum creatinine or INR. You still use the serum, the patient weight, clinical status, and for now, basically that's what we use for now. And we're still looking forward, by the grace of God. Thank you very much.
Let me see. Hello? Hello?
Yes.
Hello? And yes, okay, I noticed some questions in the chat. Let me see. That. Okay, there's a question on the difference between assay and TDMs. I would say that both are being done, but the TDM more or less is recent. I would say it's recent as against the assays. And the assays, if I would believe, is done more or less on a small scale. So, and the small scale is obviously because of cost. I don't know if that answers the question. Hello?
Yes, please, the presenter. Over
Yes.
to you.
Okay, yes. Then I don't know if that answers the question on TDM, on assay, difference between assay and TDMs. Okay.
It does. It's okay. It's okay. Thank you.
And there's a second question here on using creatinine clearance alone for dosage adjustments. Is that not still generalization instead of individualization? If you remember, I mentioned 3 pillars that are employed in TDM. They include toxicity, dosing, and monitoring. For creatinine clearance, it's not generalization. You're more or less focused on the organs of metabolism, the kidney. That's the kidney in this question. And because it's meant to clear the drug, if there's a situation where there's a clinical, where the drug, the organ is not functioning, or there's a failure, obviously the drug, if has a low therapeutic index, will definitely pull up in the system, and that will push the patient to further harm. So the creatinine clearance is more or less focused to the kidney. Contribution.
And there's yet another question. Thank you very much for that answer. There's another question.
Okay.
On the chat box.
Okay, and that's
saying what is your take?
On between additional dosing of
okay, go ahead.
Gentamicin and extended release. I would say because of the documented toxicity of gentamicin that we all TDM is massively important in this situation, particularly if there's a confirmed case of organ compromise or failure. Be it extended release or a normal dose gentamicin, that patient has to be subjected to TDM, because TDM now will tell us the amount of gentamicin that should be administered to that patient.
Thank you very much. I hope that answers the question. Please, are there other comments or contribution to the presentation tonight? In the any other question, any other contribution or question? Okay, if there are no other comments, I want to say a very big thank you to our presenter today. Hello.
Hey, hello. Okay, thank you, ma'am.
Okay, and to Plateau State, our host state, you have done marvelously. We appreciate your presentation and for accepting to make this presentation even within a short interval. We are happy. Thank you very much. And at this point in time, we want to call the National Vice Chairman, Dr. Maureen Wafo, to please say the closing remarks before we close the meeting for tonight.
Okay. Once again, good evening, everybody.
Good evening, ma'am.
Of our national chairman, thank everybody that made it today to this presentation, despite the hitches we had earlier. Thank you very much. Want to appreciate our presenter, Sipan. Did a very good work this evening to really make us understand the need for us to really press on for all our tertiary hospital, at least to have this equipment that will help us patients, drug therapy, in order to control obesity and able to give them the correct dose, especially those drugs that have a neurotherapeutic index, aminoglycoside, and the rest. We'll continue to pray that God will help us when the world gets this basic equipment to help our patients. So once again, thank you very much, Plateau State and our Apple presenter. You did a great work. Thank you very much.
Thank you.
I say once again, thank everybody that really made it tonight. I pray that next week we'll all come here again to listen to another great presentation. Thank you very much. So
Thank
you.
Thank you.
Thank you. Thank you. Thank you, our able Vice Chairman. So with that, we will bring the meeting to a close tonight. And then I want to invite everyone to the next meeting on Friday. Coming Friday, we are going to have a meeting from one of the CPAN specialist group. So please do well to join the meeting. And at this point in time too, I want to call on Dr. Agada, Dr. Ichofu Agada, to please take the closing prayer. Dr. Agada, please. Hello. It seems he's no longer with us. Okay, please, can Dr. Ifeoma Mama take the closing prayer? Oh. Please, Dr. Ifeoma, are you around? Are you still with us? Network issues. Oh, okay. Please, a volunteer can give us the closing prayer. Seems the two people have been cut off by network. Please, anyone that is led can give us the closing prayer. Thank you. Okay, let me take the prayer then. Oh. Let's go. Okay, Lord, we thank you for this privilege. We thank you for the meeting tonight. We thank you that you have seen us through despite all that happened at the initial stage. Thank you for the knowledge that has been imparted unto us. Help us, dear Lord, in our individual practices to implement this knowledge for the safety of our patient. In Jesus' name.
Amen.
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 Good night, everyone. Thank you again for coming out.
Good
God
night.
bless you all.
Right. Good night, everybody.
Good night, everyone.
Rest well.
Good night.